Welcome, and thank you for taking the time to listen to my presentation on my doctoral research project. I explored the challenges that the outpatient physical therapist encountered when trying to implement an evidence-based research protocol. I want to extend my sincere thanks to all the physical therapists in North Dakota, South Dakota, Minnesota, and Montana who volunteered to be participants in my research project. I know just how busy all of you outpatient physical therapists are, but your efforts have provided this rich data that will now be used to help future clinicians with their evidence-based implementation. I am a physical therapist and a certified athletic trainer that's worked clinically in the sports medicine outpatient setting, as well as presented at local, district, and national level. My manual skills, especially my strain counterstrain, began to attract very challenging chronic pain patients. It was my need to seek further evidence on caring for these complex patients, as well as my enjoyment of teaching, that had me considering a transition into the academic arena. I was then recruited to Michigan State University as a teaching and research assistant for my PhD, which then led to the completion of this research project that we're talking about today. I will be providing an introduction as to why I chose to do this research project and the methods I employed to carry it out. Then I'll present the findings in comparison to the published literature. I'll finish with limitations of this study and a discussion for a proposal for future research. In the past 30 years, evidence-based practice has replaced the traditional emphasis of learning from authorities. This transitional change has led to many different changes, both academically and clinically. Academically, we have watched as the entry-level physical therapy degree has transitioned from a bachelor's toward a master's, and now at the present doctorate level. In addition, we've seen a significant increase in the physical therapy research that's been published. Unfortunately, clinical practice has not transitioned as quickly. The literature shows that physical therapists use evidence-based practice less than 50% of their cases. Overall, in fact, physical therapists still base their decisions off their entry-level education and their personal experience. What are the barriers or challenges that the clinicians encounter that could be disrupting this evidence-based practice transition? Exploration of the research documented the presence of several potential barriers. The barrier listed with the most frequency was lack of time. Clinicians reported that implementing evidence-based practice required additional time that just was not available with their busy clinic schedule. Several more challenges were presented and fit into three main categories: research methods, clinician skills, and work environment. The first area involved various issues with research methodology. Some authors support that physical therapists should only read and utilize random control trials when searching the literature, while disregarding lower levels of evidence. However, there are challenges with using only this gold standard random control trials, as some of the study designs led to findings that are difficult to generalize into clinical practice. Some random control trials showed insufficient consideration of the study sample composition, whether the treatment intervention could be clinically acceptable, or whether the best measurement outcomes were selected. The inherent variability in patients, as well as the patient-therapist interactions present in physical therapy, may further complicate the applicability of random control trials. Last, the assignment of this gold standard to random control trials can actually deflate the contributions from qualitative research. Another area in which research and clinical practice conflicts for physical therapy is that most physical therapists choose a range of treatment approaches and techniques, while an experimental therapy research selects only one intervention to simplify the research question and to minimize confounding variables. These single research interventions make comparison to usual therapy difficult. Another area was publication bias. The Cochrane Central Register of Controlled Trials lists several physical therapy-related random control trials are completed, but unfortunately, some are not published. Medical research trials that are non-significant findings are less likely to be published, or are published with greater delay than research with significant results. The odds of publishing have been estimated as 2.4 times greater if the study results are statistically significant. This bias could be eliminated if all random control trials were published in a timely manner, regardless of the outcomes, and one suggestion to aid with this would be a mandatory registration of all clinical trials. Another challenge was finding that a research study, if it would actually match that physical therapist practice. While some physical therapists encountered this difficulty, they will actually discard the study results. Unless the patient possesses characteristics that contradict the intervention, it's actually recommended that the PTs take the results and adjust their clinical experience to meet the patient's individual needs. Finding research relevant to one's practice is especially challenging for physical therapists treating pediatrics or occupational health, where very few random control trials have been conducted. The next area was the challenges found for clinician skills. Fell and Berman explored factors influencing clinician skills to access and interpret research. The authors emphasized that the best way to encourage evidence-based practice in healthcare was to improve the ability of professionals to identify, locate, and retrieve the research articles. One of the barriers that was discussed was the culture of practice, which emphasizes routine patient care. Healthcare providers have been reported being unaware that a guideline even exists, or they do admit they lack the skill to incorporate the information into clinical practice. The author Summerson recommended that clinicians must be able to critically evaluate their own individual practice. In a recent publication by Devera Berardo, it employed physical therapists to routinely question their habituated and traditional practices while seeking evidence to support their clinical decision-making. Devera Berardo felt that the failure to utilize critical self-assessment during evaluation and treatment of patients could actually lead to ineffective interventions. While the data does demonstrate that evidence-based skills can be learned, especially in the area of accessing literature, critical appraisal, and decision-making, there's actually a lack of data to show that this teaching has resulted in long-term alterations in clinical practice or patient results. The next area of work environment, researchers found that the development of skill to search and acquire research will be wasted if affordable access is not available. While most physical therapists rely on web-based search engines, few of these are available to individuals free of charge, unless the physical therapist is granted access by a larger teaching facility or hospital. In addition to the report of lack of time being a challenge, clinicians also noted that there was a growing emphasis on healthcare productivity that encroached on their time to search, read, and implement the evidence-based information into their daily practice. Some clinicians reported experiencing resistance when they did try to change their practice. Some noted resistance from physicians, others noticed resistance from their own peers. Some reported a reluctance of the administration to support these practice changes, especially if facility finances could be affected. The definition of evidence-based practice that was used for this study was the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of the individual. This includes this triangle representation of using the printed scientific literature in addition to the clinician's expertise and underlined by taking into consideration the individual patient's perspectives and feelings. What is the impact when physical therapists choose not to implement evidence-based practice? Well, let's consider chronic low back pain patients. Chronic low back pain has been recorded as one of the most common reasons for patients seeking health care. In fact, it's been recorded as the most prevalent socio- and economic problem. The prognosis, unfortunately, for caring for these chronic low back pain patients has not improved. In fact, research is showing there's little consensus among specialists when you determine what they want to do to evaluate or even manage these chronic low back pain patients. Just consider, if more physical therapists would commit to implement evidence-based practice, would this make a difference with either the treatment or the prognosis of chronic low back pain patients? Even if evidence-based practice could make a difference with patient care, the next question is, are physical therapists willing to make the transition toward evidence-based practice? A survey that was done by Jet al. to examine the beliefs, attitudes, knowledge, and behaviors of physical therapists within the American Physical Therapy Association was completed. With that survey, they had over a 48.8% return rate. From that study, the findings showed that majority of these physical therapists agreed or strongly agreed that evidence-based practice is necessary. 82% did agree that literature helps with their treatment. 79% felt that the use of evidence-based practice will improve the quality of their patient care. Another 72% supported that evidence is useful in decision making, and over 84% felt that practitioners, they do need to increase the use of their evidence in their daily practice. Now, caution is needed when considering the Jet and colleagues' 2003 study. An important limitation is that the survey contacted only members of the American Physical Therapy Association. The APTA annual report from 2012 reported that there were 54,308 physical therapists who were members of the APTA. The United States Department of Labor, though, lists the total number of licensed physical therapists in the United States in that same year of 2012 at 191,406. These numbers show that only 28% of licensed physical therapists are members of APTA. Therefore, all licensed physical therapists should be surveyed to determine a more accurate assessment of the physical therapy profession. Before an intervention can be designed to assist clinicians in transitioning toward evidence-based practice, there needs to be a deeper understanding of the challenges that the PTs face. The literature utilized survey methodology to question the PTs retrospectively. This study was designed to provide a real-time implementation with interviews in an attempt to gather more specific information. The purpose of my research project focused on two research questions. One, what challenges do the physical therapists encounter when implementing the graded activity protocol for chronic low back pain into an outpatient physical therapy setting? And two, what recommendations do physical therapists have to overcome the identified challenges? The participants for this study were recruited by the snowball method. First, I emailed requests to physical therapists who provided student clinical affiliations with the University of Mary in North Dakota, South Dakota, Minnesota, and Montana. Each physical therapist that volunteered was encouraged to reach out to their coworkers and friends to see if they might also be interested in participating. The initial goal was to recruit 18 physical therapists, seeking physical therapists from all 3 levels of entry-level education at bachelor's, master's, and doctorate. We were able to successfully recruit 21 physical therapists, and over the time of the study, we did lose 4 physical therapists. Six months after the start of the research project, there was a concern when 8 out of the remaining 17 physical therapists had still not attempted an implementation of even one chronic low back pain patient. Because of the concern for numbers, we did an additional recruitment and we added another 11 physical therapists to the study, bringing the total to 28 physical therapists. I realized that I also needed to reach out to those physical therapists who had not implemented the graded activity protocol, as obviously they were encountering challenges. Instrumentation for this study consisted of interviews that were short, open-ended questions to encourage discussion. The initial demographic interview took place in either a company conference room, an educational classroom, or a private treatment room to reduce background noise. Being careful to obtain permission before recording. The recording was done with a Sony recorder, and then the recording was transcribed afterwards. Once the initial interview was completed, then those participants, including any other additional coworkers who were interested, were given a workshop training to teach the graded activity protocol. This included a written training manual, and then the investigator was available by phone or email for questions. Once the training was completed, the physical therapist was instructed to try to implement the graded activity protocol on 2 chronic low back pain patients. The midway interview was to be scheduled once the physical therapist had begun the implementation on 1 chronic low back pain patient, or when 3 months had passed after the workshop training. The final interviews were conducted when the physical therapist had concluded implementation with 2 chronic low back pain patients, or by the end of the study in September 2014, to be able to include those physical therapists who had done no implementation at all. By the end of the study, we had gathered a total of 28 final interviews, which was nearly double the amount of data that was originally planned. When reviewing the midway interviews, we noticed several repetitious comments that did not add to the theme immersion, so analysis was focused on the final interviews. In order to fully understand the findings of this research project, I think it's important to talk about the qualitative data analysis process. I will do this by taking the next several slides to show screenshots of the process of data analysis, going step by step, talking about reading of the transcripts to find the code words, organizing those code words, formation of common themes, and then ranking themes into higher and lower order. This is a snapshot of a small part of a final interview of one of the participants. The first step of the qualitative analysis involved reading all of the transcripts of the final interviews and summarizing the participants' comments, as noticed by the words in red. The short, summative comments that answer the research questions would later become code words, or also known as lower order themes. Next, the code words for each question are reviewed and organized together by a common idea. In this example, the participants were expressing reasons why the graded activity protocol did not work for their patient. Once the code words are brought together, then they're examined for the emergence of themes. In this example, the emergent themes became the lack of opportunity, not responding well to treatment, and difficulty finding the right candidate. Next, the emergent themes are examined for relationship. In this example, the three themes of lack of opportunity, not responding well to treatment, and difficulty finding right candidate all represented a higher order theme of lack of fit for individual patient. There were 2 steps taken to ensure the trustworthiness of the data for this study. The first was member checking, also known as informant feedback. This is a technique to improve accuracy, credibility, validity, and transferability of the study. During the interview, I would restate or summarize information and then question the participant to determine accuracy. Second is investigator triangulation. 2 other researchers trained in the qualitative data analysis performed the same process as described in the previous 4 slides. Then the 3 investigators compare their findings and come to an agreement. This often leads to very fun discussion and compromise. At the conclusion of the study in September of 2014, final interviews were completed on 28 physical therapists. 9 out of the 28 physical therapists did not successfully implement the graded activity protocol on a chronic low back pain patient. This is 32% of the participants who encountered challenges significant enough that implementation of evidence-based practice failed for them. Here is a chart summarizing some of the demographic information on the final participants. The pseudonyms beginning with the letter D represent physical therapists who've graduated from physical therapy school less than 5 years ago, while the pseudonyms beginning with the letter J have graduated from 5 to 15 years ago. Note that all of the first group received a DPT, while the majority of the second group received a master's degree. Due to the rural nature of this region, some of the physical therapists also had some inpatient responsibilities. The graded activity protocol was implemented, though, on patients seen in the facility's outpatient setting. Also, note that while the graded activity protocol has been shown to be effective for treating chronic low back pain patients in the research literature for the past 40+ years, none of these physical therapists have utilized the technique, and several had never even heard of it. This part of the chart shows the group with pseudonyms beginning with the letter R, and they were physical therapists who had graduated from physical therapy school more than 15 years ago. This group showed 5 participants with a master's degree and the other 7 with a bachelor's. 3 of the participants have completed a transitional DPT. It's interesting to note that this group has 2 physical therapists who actually have tried the graded activity protocol with their patients, while on the other hand, 6 others had never heard of it. The real-time study design was selected to avoid missing information that could be forgotten over time when data is gathered retrospectively. This choice of doing things in real time created an important change, particularly when you consider the evidence-based practice model. Note that by my taking care of all of the scientific information, that removed one side of this triangle completely. It just leaves the clinical expertise and then the patient-client perspectives. Now, while this is different and not the complete representation of evidence-based model, this study, though, does mirror something that's quite common in a clinical setting, and that is it mirrors our continuing education that the clinicians receive. While I did analyze the entire final interviews for code words, it was the following 3 questions that elicited the most information to answer the study's main research questions. They were the questions of: describe your experience in implementing the graded activity treatment protocol for your chronic low back pain patients. Then, describe any challenges you encountered while using this new graded activity approach with your chronic low back pain patients. And then last was the question of: list some suggestions to overcome the challenges that you encountered. The analysis process consisted of my summarizing the participant statements, organizing the code words, reviewing those code words for emergence of themes, and then ranking them into higher and lower themes. Then I debated, discussed, and compromised this information with my committee chair, Dr. Marty Ewing, and my committee member, Dr. Tom Makowiak, for triangulation process. The next slide that we will show is a final representation of this research study's data. This chart is a representation of the final results of this research study. The central black box highlights the 2 research questions, which were: what challenges do the physical therapists encounter when implementing the graded activity protocol for chronic low back pain patients in outpatient physical therapy setting? And number 2, what recommendations do the physical therapists have to overcome the identified challenges? Note that the results that answered the first question about challenges, the words are not underlined, while the results that answered the second question, those words are underlined. The results revealed 4 major themes that are in the first bold boxes and are each in a different color. The first major theme is physical therapist buy-in, seen in blue. The second is lack of fit for individual patients, seen in brown. The third, administrative aspects of clinics, seen in red. And the fourth, requires educating others, as seen in green. The next level of boxes are the sub-themes. So for example, for the major theme of physical therapist buy-in, the sub-themes for that are commitment to change, successful implementation, and motivation to change. Then those words that are not in a box, those are the lower order themes. So for example, for the major theme of physical therapist buy-in, it's a sub-theme of motivation to change, which then came from the lower order themes of just go for it, stick with it, opportunity for a new tool, or a new way of thinking. This data will be discussed in greater detail when talking about the results. Once the data analysis is complete, it's important to reflect back on the research questions. And it's very interesting to note that participants shared a large volume of information about challenges that they faced when attempting to implement the graded activity protocol for their chronic low back pain patients. In contrast, when the participants were asked what recommendations they had to overcome those identified challenges, they did one of 3 things. They either gave a very short answer for a recommendation, or they spent time discussing another challenge. And even more interesting, I had several who just stated they had no recommendations and the comment was done. When taking the results information and coming back to the research questions, for the first questions, What challenges did the PTs encounter? That was reflected in the information of the major themes of physical therapist buy-in, lack of fit for individual patient, and then the challenge of administrative aspects of the clinic. For the second question, what recommendations do the PTs have to overcome the identified challenges? This was answered with the major theme of requires educating others, as well as the sub-theme of motivation to change. The results of this study confirmed that challenges will arise with evidence-based implementation, which could clearly be seen with the large volume of information that arose when the physical therapists were questioned about these challenges. In addition, the results also confirmed something very important. Evidence-based practice is not a solo event. It isn't just about the physical therapist, and that will be seen as we go through those results. It also involves the patient, the physicians, the general public, administrators, co-workers, physicians, etc. There's so many other aspects than just the physical therapist. Well, we did share that the most frequent challenge found in the literature was lack of time. But this study, overwhelmingly, the most commented on challenge was the physical therapist buy-in. Two other key differences that were found with this study is that physical therapists must undergo a behavioral change. It's interesting that there was very little, if anything, reported on this in the research. In addition, the action of the implementation itself is actually a very necessary part of learning the new technique and is therefore influential in motivating the behavioral change. Now I would like to share how the literature compared and contrasted with the findings in this study. I'll begin first with the major theme of physical therapist buy-in, which comprised the subthemes challenges of commitment to change and successful implementation, and the subtheme recommendation of motivation to change. As this was a qualitative study based on grounded theory, it's important to discuss relevant theories. First, for the major theme of physical therapy buy-in and the subtheme of commitment to change, the relevant theory is the trans-theoretical model. Perhaps one reason that the lack of time is the most commonly reported barrier for clinicians is that some clinicians are actually struggling with trying something new. The process of implementing a new technique into the clinical setting will require the clinician to undergo a behavioral change. One of the most widely accepted frameworks for understanding behavioral change is the trans-theoretical model. Procasta and De Clemente proposed the trans-theoretical model to explain and predict successful change that could produce long-term adherence of a new behavior. People were described to move through 5 consecutive stages of pre-contemplation, contemplation, preparation, action, and maintenance. Pre-contemplation denotes that an individual is unwilling, unaware, or uninformed about changing a particular behavior. Some people might actually be defensive, as the positive aspects do not outweigh the negative at this stage. These individuals are not willing to assume ownership and will be unresponsive to intervention strategies. Contemplation illustrates a willingness to seek out information as the individual considers the possibility of a change. While contemplators will assess the options and weigh the pros and cons, they're not quite prepared to act yet. These individuals are just at the I might stage. The attitudinal shift that will prepare the person to act progresses them to the next stage of preparation. These individuals will then organize, set goals, and prioritize in order to avoid potential failure. The preparation stage represents a stage of readiness for change. When the person transitions toward overt behavioral modification, then this is identified as the action stage. The individual actively tries the behavior. The final stage, maintenance, produces a changed lifestyle that holds up long term. Now, individuals can progress through these stages at their own rate, and even more importantly, the progress could be either forward or in a backward direction. When a person moves backward in the changes, this is known as a relapse. Forward progression to the next stage requires the person to complete specific tasks. The pre-contemplator must accept that change is needed. The contemplator actively decides to change and plans to act. During the preparation stage, the individual develops a specific plan of action while resolving uncertainties toward the new behavior. First, let's apply the trans-theoretical model to the data from the major theme of physical therapist buy-in, subtheme, commitment to change, and the lower order theme of forgot to implement. Janet reported, those first couple of weeks were so crazy, were so busy that it was out of sight, out of mind, and I forgot. Her coworker, Jennifer, stated, so for me, if it's out of sight, it's out of mind. So I found it was really crucial for me to put that flow sheet, that first thing of a flow sheet in the chart, and immediately, as soon as I saw that patient, when I would type their note, and that just helped me kind of remember that on the first session and not put it off for another session. When you apply the trans-theoretical model to the quotes of these two participants, you will see that Janet was at pre-contemplation while Jennifer was at preparation. Janet and Jennifer were actually co-workers at the same facility. This facility was facing heavy patient loads due to administrative challenges. It's also important to point out that Jennifer's interview was actually done 3 months prior to Janet's. It is interesting to note how the two physical therapists reacted so differently to the same challenging conditions. For the lower order theme of trying something new, participant Reginald noted, there's no question. I rely on my experience now, my professional judgment, because quite frankly, and how do I want to say this, you've almost got to sell me on this approach too. When you compare this with the trans-theoretical model, Reginald is seen to be in the pre-contemplation stage. Perhaps an intervention is needed to educate him about the biopsychosocial pain model in order to help him transition to the next level of behavioral change. A slightly different factor was seen with the lower order theme of partial implementation. The significant element not being utilized here was the fear avoidance belief questionnaire. Dylan commented, no one in my clinic uses the fear avoidance belief questionnaire. This seems to be related to potential groupthink, which may have reduced Dylan's motivation to change his assessment practice. An intervention in this particular case might need to be directed at the entire work group rather than just the individual. It's also important to point out, for this particular research study, several physical therapists did not use the fear avoidance belief questionnaire, even though it was recommended during the workshop training. Before presenting the data for the Subtheme-Successful Implementation, I need to introduce another theory. When the physical therapist commits to implement evidence-based practice into their clinical practice, the situated learning theory proposes that the physical therapist will learn the new technique differently as compared to just reading the technique in a journal or hearing a presentation at a continuing education seminar. Situated learning theory would identify the physical therapist as the cognitive apprentice who will develop an understanding of the evidence-based technique by practicing it in their natural clinical setting. The physical therapists interact in this community of practice with others by sharing ideas during the implementation process. This active learning environment contrasts with the passive experience of the continuing education class and supports the importance of the physical therapist needing to commit to try the evidence-based practice. Without this commitment to try the evidence-based practice, the physical therapist will not have the opportunity to gain the knowledge that will occur when interacting with the new information in their new natural setting. For the next lower order theme of setting appropriate goals, participant Dylan stated that collaborative goals, those are just super important. I'm going to do it because if they don't know what they're pursuing in therapy, then I just don't think that is appropriate at all. He summarized that setting direction is important for this patient. While we do set goals for all patients, setting the goal at this stage is especially relevant for chronic low back pain patients. With the graded activity, the first 3 visits are all about creating a safe environment for the patient. On that 4th visit, once the goals are set, this provides a new focus for the patient. This is when you have the attentional shift, the shift from them focusing completely on their pain and what they're feeling, to now turning their attention and focusing just on function. This is especially important when we talk about fear and anxiety, which will be described in the next slide. The graded activity is a technique that's designed to specifically address this fear and anxiety. The fear avoidance model is an integral part of explaining why graded activity is effective for chronic low back pain patients. When you look at the center of this slide, it begins with an injury. All individuals for that injury will then react differently depending on their perception of their pain. If they have a very low fear response to the pain of their injury, then they will proceed to confront that pain and then therefore to recover. It's those individuals who have very high fear that unfortunately go in the other direction. For some individuals, this fear is so high they demonstrate characteristics known as catastrophizing. When this individual has just had so much focus on fear that they are no longer even thinking rationally. These are the kind of individuals you see in your office who sit there telling you quite calmly that their pain is a 12 out of 10, and yet they don't seem to display any emotion. This should be a red flag for you to begin to consider, is this individual catastrophizing? If you haven't done the fear avoidance belief questionnaire, make sure you pull it out at this stage. These individuals who catastrophize will demonstrate 2 important behaviors. Because of their fear of their pain, they will choose to escape anything that they are concerned about elevating that pain. They're so anxious that they'll actually even avoid it. These are the individuals who come up with all kinds of excuses why they can't attend your session or they can't complete the exercises you ask them to do. The unfortunate part of these fear and anxiety behaviors that lead to escaping and avoidance, it becomes a self-fulfilling prophecy. Then these individuals do end up with disuse, disability, and depression. And then these 3 will actually do what? Alter their pain perception even more, and now the fear is actually reinforced. And they get stuck on this merry-go-round of catastrophizing, fear, anxiety, disuse, disability, and depression, and they just keep spiraling around. It's graded activity in trying to specifically address the fear and anxiety that's going to get them off of that merry-go-round, shift them into the other direction so they can confront this pain and then recover. The next lower order theme summarized that patient education was an important element for successful implementation of graded activity protocol for chronic low back pain patients. Dawn expounded on this point. I guess kind of giving the patients a heads up, that we may not be directly addressing that pain of yours. The physical therapist realized that graded activity was very much a new way of addressing pain. Research supports the need to educate patients about pain. Mosley showed that improved pain and disability for chronic low back pain patients occurred with pain physiology education. Ryan, Gray, Newton, and Grant supported that. They showed a reduction in pain with improvement in pain self-efficacy scores for chronic low back pain patients with individualized sessions of pain biology sessions versus group sessions. This research supports the need to meet each patient individually, see where they're at, and then address them with the education that they need. At first glance, one would assume this next lower order theme of patient buy-in could be achieved with patient education. But the participants eloquently point out that more than patient education is required to achieve patient buy-in. Rachel summarized, getting them to buy in to exercise and finding the right level. It's not so much the graded protocol and giving them empowerment. That's not the challenge. It's just getting the clients to buy in. And it's difficult to, like I said, once something becomes their everyday norm, it's getting them to think, so hey, this isn't the norm. I'm getting them to switch. Dan mentioned, hardest thing is compliance. They won't even come in. In addition to patient education, Jim felt that there was a need to alter their mindset, while Jason expressed that you needed to overcome patient information. Roger shared it was also needing to instill patient trust. And last, Ralph reported it was about altering patient expectations. So much more is involved in patient buy-in than just education. It is a matter of changing their mindset, overcoming misinformation, instilling a trust in order to be able to alter their patient expectations. It is possible that lack of time was mentioned by only a few physical therapists in this study because of the elimination of the need for the physical therapist to search, access, read, and interpret the written literature themselves. While there were only a few complaints about lack of time, it was still a viable challenge, as seen by participant Janet's comments. I felt the time frames were tough. It got crazy here with schedules, and most of my appointments were a half an hour. It should be noted that the graded activity, particularly of the first few visits, takes a good 45 minutes up to an hour of time. The next sub-theme was a recommendation, a motivation to change, something to overcome that commitment to change in the major theme of physical therapist buy-in. Dawn shared, I would just say go for it. The protocol, it's simple to follow. Theory of planned behavior supports that a person's intention is the most important variable for predicting behavioral change, and that an individual's personal motivation can actually be the one thing that will help alter their behavior. The next major theme, lack of fit for individual patient, discussed the challenges that completely disrupted the implementation of graded activity. The first sub-theme, lack of opportunity, included the lower order themes of not PT specialty and patient treatment preference. Participant Darla commented, "We all kind of have our own niche here." It's important to note that during the 9 months for this research project, the participant Darla never requested to have a chronic low back pain patient placed on her schedule. I saw this more as a lack of commitment rather than just the hindrance of her PT specialty. As far as patient treatment preference, Jim shared, they've had a history of modalities and they avidly request modalities. In this particular case, the workshop taught the physical therapist to refrain from the use of passive modalities, as this might lead a patient to think that the tissue injury is what's causing their pain rather than just sensitization of the nervous system. It's possible that this physical therapist overrode this workshop recommendation, particularly when he had to take into consideration if the patient refuses to come for treatment, that can then mean financial consideration. The subtheme of patient not responding well brings up the important aspect of understanding the biopsychosocial model. Dan shared, "So we implemented it, but it seems to be, we would do a few treatments and things go wrong. Then we would throw one exercise in that just set her back. And Jim noted she would tell me, this is hurting my shoulder, this is hurting my leg, this is hurting my foot, Both these individuals were showing that the treatment had not gone well because the patient reported an increase in pain. Research clearly points out this seems to be a misunderstanding between biomedical and biopsychosocial model. The biomedical model, pain does equal tissue injury, but biopsychosocial shows that pain is a multi-dimensional expression of the physical, social, and psychological aspects. That chronic low back pain patients' pain is driven by these psychological factors, particularly that fear and the subsequent pain avoidance. When the physical therapist immediately responds to their complaints of pain rather than educating them, this can actually perpetuate that fear and avoidance behaviors that can then perpetuate chronic low back pain. It is very common for patients with high fear avoidance belief questionnaires to report pain anytime an exercise is introduced. The subtheme of difficulty finding the right candidate was an unexpected challenge. In the initial interviews, participants were asked, "Give me an estimate of the number of chronic low back pain patients you see in a month." The estimates given range from 1 to 3 chronic low back pain patients to as high as greater than 20. Even if I remove the top 3 estimates from those individuals who specialize in chronic pain, the average was still 5 chronic low back pain patients a month. Despite that very healthy estimate, 4 physical therapists reported not seeing any chronic low back pain patients. An additional 5 said those few chronic low back pain patients they did see did not fit the protocol. It is important to note, though, that these individuals who were having difficulty finding the chronic low back pain patients inconsistently used the fear avoidance belief questionnaire as an outcome measure. When you dig deeper into this subtheme of difficulty finding the right candidate, something else comes up. Jennifer stated, there were, again, not ideal patients as far as, they had a lot of comorbidities. Janet added, it's more just kind of getting all those criteria in for that one person. I think it was hard to try to classify. The research discussed some of these comments. They noted that some physical therapists will show an all or none approach to an evidence-based practice implementation. Some physical therapists will actually just discard those research results when it fails to match their clinical practice, when the recommendation is they need to use their clinical expertise in order to accommodate their individual patient. When they make those individual adjustments, yes, it will take a little bit more time and effort by the physical therapist, so therefore a higher level of commitment to change will be needed. The next major theme is administrative aspects of the clinic. Darla shared that coworker that has left us, and he was kind of the head. This supported the subtheme for lost leadership. Research shows that this leadership support was closely linked with positive staff attitudes and beliefs about evidence-based implementation. In addition, presence of a peer opinion leader who can demonstrate the ability to implement the protocol will provide improved confidence for coworkers, especially in the late stages of implementation. Justin shared a particular challenge for their amount of chronic low back pain referrals. The pain management person who generally made significant amount of referrals, her employers cracked down on her to keep her referrals in-house. No patients, no implementation, a pretty significant issue. This particular issue, though, is categorized as a political influence, and it would require intervention from a much higher regulatory body. Justin shared, we are short-handed for this area, and then to try to get people in, but the schedule is very difficult right now. Literature showed that staff shortages exerted increased demand on the remaining staff members. In addition, when there's inadequate staffing, it was a very significant challenge for any implementation of evidence-based practice, including a resultant negative staff attitude toward proposed changes. So it wouldn't matter how committed a physical therapist is to try it. This challenge sometimes cannot be overcome. The last major theme that will be discussed includes a recommendation to overcome a challenge. It was requires educating others. The subtheme of medical community. Jim shared, I think it's more, as like you said, raising awareness, even from the other medical community, such as the physicians, physician assistants, and nurse practitioners. We need them to recognize what is going on with these patients and then make the proper referral for a graded exercise program. Jim noted two things. One, of course, any increased referrals would increase potential chronic low back pain patients. But he also realized that there was a need for the medical community to show support for this graded activity that can make an impact on the patient's willingness to go through with it. Barnett et al. Shared a qualitative study that showed that support among health profession groups was a major theme that's needed for implementation of evidence-based practice. It was especially important to start a project, as well as to provide the driving force to complete the project. The trust and mutual support between the different professions was a prerequisite in order for them to cooperate. Dobson and Fitzgerald pointed out that differences in training creates unique knowledge bases. For example, physical therapists and the physicians both have their own unique knowledge base. These unique knowledge base also leads to unique group attitudes. And if these group attitudes go unchallenged, it can actually create resistance when the groups try to work together on a mutual project. It's especially a resistant force if there's a difference of power of the two groups. Cooperative partnerships were found to actually aid evidence-based implementation. For the subtheme of insurance companies, Justin noted, I think one big thing is the insurance companies need to be a little bit more open to new treatments. This comment is very similar to the comment of public perception, because when there's this shift from traditional care occurs, educational updates are needed in order to provide the insurance company with what changes would be best for their patients. The next area is the subtheme of administrators. Jason shared, I need to educate the people above me to have that same important understanding if they don't stay current. With evidence-based implementation, the spotlight is very much on that individualized practitioner. There's been an assumption that administrators will prioritize finances and therefore will be negative toward evidence-based. But actually, literature has shown that to not be true. That actually those evidence-based projects that show the most progress, they had the senior managerial support behind them. This leadership support was closely linked with the positive staff attitudes and beliefs that are needed in order for the implementation project to go forward. Key elements being that senior management is helping with the provision of adequate staff and equipment in order to provide any release time and replacement support. In some cases, those administrators actually became the actual champion of the project itself. It was also shown that coworkers often need education. Teamwork and collaboration were seen as critical elements for evidence-based implementation. In fact, that coworker can serve a role as a peer opinion leader. This individual, when they're willing and on board, can be a very strong influence toward the late stages of any project. Conversely, any lack of cooperation among coworkers was noted as a significant challenge. The last subtheme under requires educating others is advocacy. And this was well summarized by Jason. I think we need to advocate for ourselves. I'm going to say it flat out. I think we are too laid back. I think we're too meek and mild-mannered. Literature supports these comments that Jason has shared. The physical therapist profession faces an image gap. Cleland et al. Identified 8 key attributes that could improve advocacy among our new young graduates. And they would be helping to teach them about collaboration, communication, scholarly practice, management, professionalism, passion, perseverance, and humility. While this study confirmed that challenges arise when attempting to implement evidence-based practice into the outpatient physical therapy setting, the types of challenges did not mirror those reported in the literature. The challenge most reported in the literature was lack of time. Conversely, lack of time was actually only a lower order theme commented on by just a few participants in the study. This difference might be partially due to the study's methodology. Participants did not need time to search, read, and interpret the literature, which has been shown to be a challenging process in the literature. The most reported challenge for this study was the theme of PT buy-in. This theme presented 2 key concepts as illustrated by the subthemes. The first subtheme of commitment to change highlighted that PTs must undergo a behavioral change in order for PT buy-in. This means that simply attending an educational workshop during the lunch hour will not be sufficient to provide the motivation to change. In addition, these PTs who do attempt to implement with at least some commitment to change will be quickly derailed when a challenge arises. Another element of PT buy-in is the second subtheme of successful implementation. These PTs noted that the active process of implementing the evidence-based practice helped to increase their physical therapist buy-in. The action of implementing is a necessary part of learning, as well as an influential factor in producing behavioral change in the physical therapist. The next theme, lack of fit for individual patient, showed the impact of when implementation does not occur. When physical therapists had either difficulty finding the right candidate, or they noted that their patient was not responding well to treatment, or they encountered lack of opportunity to try the evidence base, it became less likely they would experience a successful implementation in the future, and thus not have a change in their clinical approach for these chronic low back pain patients. The PT's negative experience with their initial attempts provided reinforcement for their resistance to change practice patterns. The themes of administrative aspects of the clinic and requires educating others about the protocol presented challenges that could disrupt a physical therapist even with a higher level of commitment to change. The challenges noticed in these themes introduce another important factor for evidence-based implementation. This process is not a solo activity. Even if the physical therapist possesses high commitment to change and strong physical therapist buy-in, the implementation can be hampered by their coworkers, administrators, the referring physician, a demanding patient load, or an unwilling patient. There were several limitations to this study, including the following. Only using physical therapists in the Great Plains outpatient settings. Several physical therapists had difficulty recruiting patients, so further recruitment was needed. Of course, there's the limitation of using an interview process. Will the participant be truthful? That's an unknown. The early transcription noted that the researcher was doing too much talking in the form of teaching. As soon as this was noted, though, corrections were made for all future interviews. This project chose a real-time implementation, which eliminated the need for the physical therapist to search the literature themselves. In addition, the use of graded activity could have been an additional challenge, because some physical therapists' philosophy and understanding of chronic pain was just not conducive with being able to understand graded activity. They just might not be comfortable in addressing psychological issues of patients. Increasing the implementation of evidence-based practice into clinical practice in the outpatient physical therapy setting could improve when continuing education addresses two key factors that emerge in this study. One, implementation requires behavior change, and two, implementation is not a solo event. One recommendation would be to have a continuing educational event that encompasses 4 strategies. First is the need to prepare the environment by raising awareness. This could be done by distributing educational information to all prospective parties, such as the physical therapists, associated medical community, patients, insurance companies, administrators, general public, etc. While this passive dissemination of information will not change behavior, it allows for a very low-cost way to raise awareness prior to the educational workshop. The second step would be to recruit and train the leaders for the project, as this has been shown to be crucial for successful implementation. A champion or administrator who supports the vision and helps provide administrative resources such as staffing and equipment can significantly help for implementation. Next, the educational presentation itself needs to consist of an interactive design based on the situated learning theory. While this will require more time and effort from both learner and instructors, When a participant assumes more responsibility for their learning, it will foster lifelong learning skills, which can improve the implementation process. The final step would be to build a supportive environment. This can be done through the partnerships and leadership that was built along the way. In addition, feedback and reminders during the implementation have been shown to assist the clinician's efforts during the implementation process. This study confirmed that multiple challenges arose when implementing graded activity for chronic low back pain patients in the outpatient setting, as noted by the three main themes of physical therapist buy-in, lack of fit for individual patient, and administrative aspects of the clinic. The recommendations that were shared by this group of PTs were the main theme of educating others about the protocol and the subtheme of motivation of change. Further study is needed to investigate which interventions will effectively improve the physical therapist's ability to implement evidence-based practice into their clinical setting. Last, I would like to extend a big thank you to my Michigan State University Doctoral Research Committee, as well as graduate support system and the physical therapy students at University of Mary. I welcome any additional comments on this particular research project, so please feel free to contact me with the contact information listed on this slide. Thank you once again for your time.